Thank you very much. Yesterday I read in one of these internet thingos that the United States spends more on plastic garbage bags or trash cans than the total health expenditure in the bottom 90 countries in the world. Just to put some of these things in perspective. This title was given to me. In fact, I'm going to do it the other way around, challenges and progress. And I'd like to start by asking you to wake up a bit and draw on your pad, notepaper, a little graph like this. And imagine this little graph represents on one axis life expectancy in Canada, and on the other axis cost per head of population in Canada, with the Canadian average right here in the middle. And so you've got some provinces which are above the Canadian average in life expectancy, and some provinces below the Canadian average in life expectancy, and similarly with cost per head of population spent on public expenditure on healthcare. So now put a little dot in which quadrant Alberta is in. So who says Alberta is in the bottom right-hand quadrant? Better life expectancy, lower cost per head. Okay, what about better life expectancy, higher cost per head? 1, 2, 3, 4, 5. Okay, about half a dozen. Who says lower life expectancy, lower costs? A couple. Who says higher cost per head of population, worse life expectancy? A couple. And who doesn't say anything? Okay, well, unfortunately the answer is that Alberta is in the top left-hand quadrant. We spend more and we get less. And that's going to be the theme of my talk. I'm going to go very quickly through some slides for the first half. We spend more per capita than the Canadian average, and of course then you've got to work out, is that the right way of measuring things? And we have a lower health adjusted life expectancy than the Canadian average. Again, there's a question about whether that's the right metric. Here's the graph, males and females, with different provinces, but Alberta is in the top left-hand quadrant. Now, we have the highest per capita spending after adjusting for health age, but in 1996, we were below the Canadian average. So over the last decade, Alberta has gone from a cheap to an expensive province. Now, why is that so? And there's an issue here. Is this an issue we need to worry about at all? So what's your position? Is that we should continue to make increases in health spending a priority? You know, this is a really important thing. We should actually value this and put money into it. Is your position that Medicare is sustainable, but the current spending increases are not? We need to improve the efficiency in the health system? Or, and you've got paying, the two aspects of efficiency, paying attention to cost of service and also what we're spending our money on? Or is your position that Medicare is unsustainable, we need to do something dramatic to change it? So they seem to me to be three of the options. I'd like you to think about where you sit, and we'll come back to that later on. So what's happened over the last decade? Alberta, obviously, its rate of spending has gone up faster than everybody else, and in particular on hospitals, gone up faster than other provinces. What's interesting is that graph was hospitals and other institutions. This is the graph on hospitals, 25% faster rate of growth than other provinces. But if you look at seniors accommodation, for example, Alberta has disinvested relative to other provinces. So surprise, surprise, our hospitals are filled up with older people who don't need to be there. About 750 beds or so in our hospitals today are occupied by people who quite properly should be at home or in another service setting. So we've made some priority choices. What do we get for those priority choices? Our waiting times are not any better than the rest of Canada. That graph was from provider's perspective, this is from the consumer's perspective, saying the same sort of thing. On the other hand, our readmission rates for 3 of the 4 conditions that are reported are better, so it's not entirely bad. Our life expectancy was significantly above the Canadian average back in 1996. The gap has actually narrowed, and so now it's actually the other way around. So we've gone backwards on life expectancy relative to the other provinces. Cancer survival rates. 5-year cancer survival rates in Ontario are statistically significantly better than in Alberta. So that means that people in Ontario, once they're diagnosed with cancer, live longer than people in Alberta. Death rates for cancer, on the other hand, have gone down across the country, but have gone down quicker outside Alberta than inside Alberta. And there are differences within Alberta too. So under the old regional structure, the different regional health authorities can make different choices about what they invested money in and the programs they designed. So as a result, Pap test coverage was different within Alberta. So if you lived in Calgary, you're more likely to be invited back for a Pap test than if you lived in Edmonton. Same if you lived in Medicine Hat, you're more likely to be invited back than if you lived in Lethbridge, and as a result there are different rates of screening across the province. Smoking prevalence has actually gone up over the last couple of years. This is the only graph that actually has an Alberta Health Services time period in it, and so smoking rates have gone up over the last couple of years, whereas they've gone down in the rest of Canada. This is emergency, this is long waits in emergency departments, what proportion of the people are seen within the desirable time, or the target time in Alberta. You can see that since 2001 there's been a steady decline in the number of people seen on time in emergency departments. These are Calgary data, and the same sort of pattern in Edmonton. There's significant differences across the province in utilisation rate. Here's the difference between Calgary in terms of bed days versus Edmonton. If you go into a hospital in Edmonton for a hip replacement, you stay 1 day longer than if you go into a hospital in Calgary. These are people who live in the city of Calgary versus people who live in the city of Edmonton. You stay 1 day longer in Edmonton than you do in Calgary. Same for strokes. You stay 1 day longer in Edmonton than you do in Calgary. And there's significant differences in hospital utilisation rates across the province. Those bottom two lines, the purple and the black, are Edmonton and Calgary. There's a greater utilisation rate in the Medicine Hat, Lethbridge, the regional centres, a greater utilisation rate in rural Alberta, and a greater utilisation rate in the remote north. So there's significant variance in the way ordinary conditions hospitalisation is treated across the province. But what's interesting, I showed you earlier that the Calgary hospital admission rate was the lowest in the province. The Calgary admission rate is actually higher than the average in the rest of Canada. So here we have a situation where our health outcomes are good, our spending is high, there's huge variation across the province, and so along came Alberta Health Services, and this is obviously my PowerPoint skills aren't as good as they ought to be. So that was a summary which basically said we're spending more and getting less. Another way of summarising is we've seen a steady deterioration in performance over the last decade on practically any dimension you care to measure, and it's not just in the last 2 AHS years, despite what you might read in the newspapers. And the demonstrable turnaround for the health system, Alberta's largest one, is not going to occur overnight. The problem was created over a long period of time, and you should ignore breathless media statements which imply that a quick fix is possible, or indeed has already occurred. So back to the problem. Is this a problem? Do we care? Is continued spending the strategy viable in the long term, or should you pursue an efficiency strategy, or is Medicare unsustainable? Well, my position is the middle one. Medicare is sustainable, but we've actually got to spend smarter to actually make sure we keep it sustainable. So, the problems are significant and there's no simple panacea. More money, in my view, is not the answer, except for growth and ageing of the population. And what we need to do is spend existing money more wisely as part of that solution. Slogans won't work. If you just say, oh, we're going to privatise, that's going to fix everything, we're going to re-regionalise, that's going to fix everything. No, I'm afraid not. Re-regionalise, you go back to the same problems you had before. Intervening at any single point will not be enough. The system is large, the problems are large, and we've got a lot of things to work on. And, of course, more of the same is not the answer. We got into this problem with a more of the same type approach. We're not going to get out of it with a more of the same type of approach. And winding back the clock is also not the answer. Despite our rose-coloured glasses, everything wasn't good in the good old days. So what you need is coordinated action across a range of fronts using innovative solutions. And that's what I tried to lead in Alberta Health Services while I was CEO. An emphasis on transparency and engagement. When they asked him, why did you climb Mount Everest, he said, because it's there. Anyone know his name?
Mallory.
George Mallory, in fact. Famous only for his quote, not for his name. Anyway, a higher Alberta is a wealthy province, despite the setbacks over the last couple of years. But a higher gross domestic product allows us to spend more. It doesn't mean we have to spend more. Health spending is the result of choices that a lot of people make, including politicians, bureaucrats and so on. And they're made by people not because of the size of the gross domestic product. What we had in Alberta is what I call a Gordon-Gekko style of management. Basically, we deal with all problems by asking for more money. If it's unsuccessful in that ask for more money, it's the fault of those nasty, unreasonable politicians. And if there's money in the bank, to be fair to the politicians, it's hard for the politicians to deny reasonable requests for spending, because every case can be a reasonable case. And so what we did was we tried to spend our way out of the problem. And here is a graph of spending increases per annum over the last decade or so. Over the period from 2000, the average increase in spending by regional health authorities and others, predecessors of AHS, was 9.8% per annum. 10% increase in growth per annum. Under the AHS years, our increase was 6% per annum. Still, much, much greater than many other provinces. But you can imagine that shift from a growth expenditure of 9.8% to 6% was actually quite dramatic. The question is, how did we get in this situation? Do we implicitly or even explicitly reward extra spending or request for extra spending? So, for example, the previous structures encouraged competition for extra money and inhibited good management. And Heather may not agree with this example, but in the previous United Nurses of Alberta collective agreement, it cost $620 million to implement over a three-year period. The agreement we negotiated cost $120 million to implement over a three-year period. And I think part of the difference was that on the employer side, there was no incentive, in the old system, there was no incentive to manage that agreement. That is, the health authorities negotiated an agreement and then went to the government and said, give us the money. Whereas on the Alberta Health Services time, we knew that we had to find the money to implement the agreement and there was no extra money. And so what we had to do was negotiate a tougher agreement in a sense. So, and what's interesting is the perspective of that. The Alberta Health Services budget, in my view, I took the view that the Alberta Health Services budget is set by the government. And so my job as the CEO was to actually manage within what was set by the democratically elected people. I'm not a democratically elected person, I was an appointed CEO. And so the government makes a priority choice about how much it was going to spend on health. And our job was to live within it. That was not necessarily the view of my predecessors. And also, because of that, the public or staff or media expectation was often that the job of the CEO was to ask politicians, especially publicly, for more money, rather than address efficiency issues or whatever. That is, to pursue option one of those three options that I outlined above. Now, actually changing that culture in saying we actually have to live within an allocated budget was actually quite tough. And one of the things we did was to start engage clinicians in the system, establishing the Alberta Clinician Council and clinical networks to actually try and harness the skills of clinicians to work in priority setting ways and so on. Saying to the clinical networks, for example, we want you to identify the problems that you're going to work on, and it doesn't matter to us where you start, whether you start on access issues or quality issues or sustainability issues, because they're all big. So wherever you think you can actually make the most leverage, whether you've got the most interest, you can start wherever you like. And what the clinical networks tried to do was to have a structure to engage the collective wisdom of clinicians versus the system of individual crusades, where individual doctors could, or clinicians could go out and campaign for their individual specialty or their individual hospital or whatever. So, we need to build an acceptance that we do live in a fiscally constrained environment and begin to address some of those issues. And of course in Alberta that's fairly hard. It may in fact be impossible in Alberta. Partly, for example, because of employment effects. I mentioned to you that Alberta Health Services is the largest employer in Alberta. Alberta Health Services is also probably the largest employer in every town in rural Alberta in every city. It's probably the largest employer in Calgary, for example. And so the employment effects of changes in Alberta Health Services are significant locally in every community. And of course, there is a trade-off, and so that's a particular issue that needs to be taken into account. Whether the health sector is a good way of maximising employment is, of course, another issue. So, Alberta Health Services needed to build the case that doing better with our existing resources is in fact possible and in fact legitimate versus just asking for more money. And that was actually quite a challenge. And will be supported politically, with skills, with hump funding and so on. Because if you're making a transition, you actually sometimes have to invest more to actually facilitate the transition. And as I've said already, health expenditure is the same as health incomes, and so the employment effects are actually quite significant. And we attempted to do this in a number of ways, one of which was to say, I'll use the example of cataracts here in Calgary. We looked at the previous agreements that have been negotiated to pay for private provision of cataract services in this city, and the contracts were pretty poor, and there's a report from the University of Calgary which actually says that. And so we went to tender and changed the arrangements. There was a huge outcry, led of course by the people who lost the tender, and the result was basically the government more or less said you have to spend more on cataracts. Now the question is, was an additional investment, I should have said that in making that change that we made, there was a 20% increase in the number of patients to be treated for the same expenditure. And this was seen, of course, as a bad thing because some of the existing providers missed out on the tender. Now the question then becomes, was additional spending on cataracts a good investment of public money? Bearing in mind the Alberta Health Services budget was fixed, and so what we were effectively doing was to shift money from something else into additional cataract expenditure. We also tried to address interprovincial equity, and I've already mentioned to you the huge variations. Interprovincial equity has a particular meaning for me, and I'll tell you what it's not. It's not Noah's Ark health planning. Noah's Ark health planning is everything in Alberta has to be done 2 by 2. One in Edmonton, one in Calgary. That is not interprovincial equity from my perspective. What is interprovincial equity is using the clinical networks to make sure that we actually learn from one another and we actually implement best practice right across the province. Here's another example of interprovincial equity. This is the cost per weighted day in each of the long-term care facilities in Alberta. So there are 180 something long-term care facilities in Alberta. One of them costs $440 something per day per resident. Another one costs $100 per day per resident. And so our position, this is a situation Alberta Health Services inherited from the previous regional health authorities, and our position was, this doesn't look equitable to us. How can those lower cost providers actually survive? Is it fair that someone is getting paid 4 or 5 times as much per day for the same resident across the province? And the same is true with hospital costs. These are the costs per weighted patient in hospitals across Edmonton, across Alberta. And you can see, for example, the Foothills costs about $6,500 per patient treated after you take into account their complexity, whereas the University of Alberta Hospital costs $7,100 or something like that per patient per day, per patient treated. Now I've said there we think because the costing information isn't as good as you'd like it to be, but there's a huge variation in cost per patient treated across the province. So there are opportunities to begin to address that without impacting adversely on patient care. So, I'd now like to ask you a little thought experiment. Think about an image of the health system. When you think about the health system, what do you think about? Which part of the health system do you think about? Hospitals, primary care, whatever. Thought experiment 2. Think about a recent media story about the health system. What part of the health system was that story about? Typically, when you think about the health system, you think about hospitals. But most contact with the health system is in primary care. There's about 10 times as many people who visited a doctor, for example, in the last year as there were admissions to hospital. So we need to think about the edifice complex. Why are we so obsessed with hospitals? Hospitals are good things, and the best way to improve health is to have more of them, with more people in them, or at least more people having access to them. And this costs money, but that's life, it's worth it. That's what we think often in the healthcare system. But what do we really get for all that spending, and is it worth it? Why are hospitals good things? Well, it's partly historic. Medicare started with hospitals. When all the problems were acute, it's probably appropriate, partly because health system leadership spokespeople come from the hospital sector. We reward that focus. Media like machines that go ping, it's visible and obvious, easy to demonstrate progress and rivers to cut. So the whole host of reasons which come to why the hospitals get the attention. Whereas we have to actually change our mindset. We have to start investing upstream, and that's what we started to do in Alberta Health Services. There's a historic overinvestment in acute beds, a historic lack of choice in the acute care system, 75% of beds in long-term care facilities, 25% in assisted living. Trying to shift that balance over a decade was not seen as a good thing. Just to stand still in this province, we need to open 1,000 additional seniors beds every year. And we weren't actually doing that over the previous decade. And we need, of course, more to deal with the backlog, and how much that backlog is a matter of debate. Again, another example, trying to actually shift the emphasis in psychiatric care from investment in institutional care to investment in community care. Again, not universally welcomed. And in fact, I was totally unsuccessful in that. And we also need to support self-management, and we didn't do that terribly well. And here is an example. Basically, if you think about a person with chronic illness, they're the person who lives with that 24/7. They're the person who can become an expert on their condition. So we have to support them in their management of that. We have to support them in training them in self-management. We have to support them in their creating a supportive environment for their partner, families, carers, and so on around them. And that means not just taking service away, but actually truly support them. We actually have to think about what we need to do in the primary care system to support the carers, to support the family environment, to support the partners, to actually support the person with the chronic illnesses. And of course, we actually don't do that. And then we have to say the specialty system is there to support that, rather than having a specialty-led health system, which is to some extent, I think, what we've created in this province. And then we have to realise, of course, that there are wider environments around all of that as well. So, what we need to do is change our system so the right person enables the right care in the right setting on time every time. The issue of waste that Stephen Lewis referred to earlier. But the word there that I want to emphasise is enables. We think very much of the health system doing things to people rather than doing things with people, or in fact enabling people to do things themselves. And I think our mindset needs to be significantly changed. Then we have to think about workforce reform as well. Again, Stephen touched on that this morning. Nutritional workforce planning, concentrating how many of Profession X we need, doctors, nurses, occupational therapists, whatever. When what we really need to recognise is a considerable overlap in skills in all of those professions, and we need to move from a profession-based to a skilled task role needs. We need to facilitate all workers to work at their full scope of practice. And Stephen's mentioned some of these already, the need to shift across that whole spectrum. We need to be open to innovation. We need to look at learning from outside. I came from Australia bringing ideas that were common in Australia but not common here, setting up medical assessment units to actually take some of the load off emergency departments, for example. But there was significant xenophobia. If you just look at the comments in some of the newspapers, the newspaper story, and then the whole set of comments about how evil Australia is, me in particular, and funny accent equals bad sort of story. We appointed an executive vice president from the UK, same sort of stories appeared. Why can't you have Alberta, things are so wonderful here. We brought people who used to work in Alberta, then worked in DC, and they brought ideas with them. So there are a whole lot of new ideas that we were able to import into this province to actually improve care. We also tried to facilitate inter-provincial learning. So there were bright ideas in Alberta that we wanted to shift to other parts of the province so that we could learn from each other in a much more cooperative and sharing way versus the competition that existed here before. We brought in expertise into the structure, we used clinical networks, and we set ambitious goals. So we're trying to create an innovative system to try and change the way that we were doing things. And we set ambitious goals. For example, we said, we want to reduce the number of diabetes admissions by a third. Just because you have lots of admissions isn't a good thing. We developed a provincial strategy on that and zone strategies on that, trying to actually, and that was a goal, I think, in my performance agreement. Another goal in my performance agreement was this one, that every person admitted to general internal medicine at the University of Alberta would get admitted to a dedicated bed in a GIM ward with an integrated plan of care within 90 minutes of the decision to admit. So I set a really tough goal. Again, this is still taking time to implement, so it's not a quick fix because it involves a total re-engineering of the system there. Another one, access to radiotherapy within 2 weeks. I'll just talk briefly on the radiotherapy story. Basically, there was a story in the newspaper here about how long the waits were for radiotherapy. So I looked at it and I thought, and the answer was, of course, more money, we need more machines, more people, whatever. And I said, okay, what is the metrics here? How many people are seen per machine per day in terms of treatment? And I asked for those metrics, and it took weeks for those metrics to come, which told me 2 things. First of all, that the Cancer Board hadn't monitored those things in the past, and 2, no one had bothered to collect those things in the past. Anyway, so I said to the people in Calgary, these metrics are nowhere near as good as they are in Australia. Let's get some Australians in to come and tell you what to do. And they said, oh, no, Australians evil, so let's fix it ourselves. And they engaged in a lean project to actually try and improve the performance of radiotherapy services here in Calgary. And they did. What was also interesting is the people in Edmonton said, oh, we're better than the people in Calgary already on these metrics, but we actually want to get better too. And so they actually started a lean project to actually improve their performance, and actually their performance improved over this period as well. And so there was using competition in effect to actually drive down the waiting time for radiotherapy within existing resources by doing things smarter. So what's my take-home message? Healthcare in Alberta is not as good as we like to think it is, and this statement is mostly backed up using data from before Alberta Health Services was formed, partly because the only comparative performance data available. Turnaround will not occur quickly, but we need to take action right now and in the future to make the right investments, start with the right ones, stop doing the wrong ones, right system design, right incentives, right workforce, spending smarter to improve engagement and patients, with both patients and clinicians. Thanks very much. Now back on time. Any comments or questions? Everybody happy? Good.
Hi, I'm Kyla Craig. I'm a health practitioner. I'm a registered nurse. I'm also a graduate student. I just wanted to identify, I read the interview in Vital Signs magazine where you identified that the resistance to change that you encountered in your position with AHS here in Alberta, and I want to echo that because I completely agree with you. I'm an emergency practitioner and I see the culture as the huge issue in our system, and in terms of making improvements towards system design and incentives, you name it, it's a very uphill battle. So I just kind of wanted to make that point.
Thank you.
And I just wanted to identify that nurses and the whole UNA, nurses don't have a choice. We start practicing and we're in the union. I think that the increase that we're experiencing now as of April, where we have this 2% that actually is going to come out of an operating budget, that's going to affect patient care. I think the union is absolutely behind the times. I think the union needs to come forward and involve with the system and start supporting the systems and supporting nurses in the right way. And I think the union is really holding back a lot of these messages that you are bringing forward. Before I get lynched, I'll probably sit down. But I think nurses, they have a passion for patient care. I think nurses have a real sense of professional commitment, and I think that AHS should be harnessing that. and working towards system improvements, because I think that nursing is quite possibly the most underutilized profession that I know of. Thank you.
Thanks. I don't want to make it, I don't think anything I said was designed to suggest that unions are a bad thing, but what I would say is this, and I agree with you that nurses are underutilised in the health system, but more importantly what I take from what you're saying is that we do need to harness the skills of everybody and their capacities to actually improve the system.
Hi, I'm back Ministry, and thank you so much for your wonderful information. I want to know what is your prediction for the future of healthcare system in Alberta?
Well, it really is an issue of what is the appetite for change. What you saw over the last decade in those pictures I gave, that information I canted through, is that basically the way all problems were solved was spending more money. And in my view, that is not sustainable into the long term in this province or in fact anywhere. So what we've got to do is actually do things smarter, do things, use the existing money more wisely, and to the extent we do that, and I think we have now got in place the structures within Alberta to do that. Whether the transition issues of that can be painful, but I think that's what we need to be doing into the long term.
You mentioned with your the cancer board example and the absence of information and then the use of it. So where do you think Alberta is in the information revolution, and what percentage of the system even has the potential to be data and evidence driven now, given how Canada is a bit of a lag in this area, and where do you see that going?
It was really interesting when I came here. I assumed there would be an information infrastructure that I was used to in Australia. And there wasn't. And it's at all sorts of levels, starting at the national level. The information available for these comparisons is very poor relative to what I was used to in Australia. And at the provincial level. And people said to me, oh, you know, Capital Health and Calgary Health were the icons of Canada. Aren't they wonderful? And I thought, well, they were like this. That's probably not true. And then they said, oh, you know, the waiting time performance was good. So I looked at the waiting time performance, and I had to say I wrote a letter to the ministry saying, I am not prepared to support the publication of waiting time data in this province because the data we have is misleading. There were different definitions between Capital and Calgary. You know, there were different ways of counting. We counted a small proportion of the total wait just from and it was just terrible. No real good. And my position was this, that if we are to improve the system, we have to take the lid off the problems and actually acknowledge the problems and say, this is a problem, we've got to fix it. Previously, the whole approach was to shut down the discussion, to not publish information, to not open it up. And you're not going to get improvement if you're not prepared to acknowledge there are issues. On the evidence issue, I think there's clinical networks are actually pretty good on that, but there is still huge variations in utilisation rates, as you can see, across the province.
Thank you, Dr. Duckett. I'm Andrea Kennedy. I'm the nursing professor at Mount Royal, and I do like your comment on the Oedipus complex, so I appreciate that phrase. You said one of my favorite words, and that's upstream, where we're looking at things that way. I find from my perspective, as a faculty member and teacher, that's something that we work on very hard in terms of training our nurses and teaching them and inspiring them. You also said something about primary care. What I want to hear from you are your thoughts on primary health care and how the Public Health Agency of Canada and the World Health Organization sees the determinants of health, and how this fits in with your vision on what we're doing right and perhaps what we can do better.
So I don't have this information here at the moment, but one of the presentations I gave, I live in inner part of Edmonton, and if you compare the life outcomes of people who live where I live versus people who live 3 kilometres to the north, there's a statistically significant difference in life expectancy from Windsor Park to the inner northern suburbs of Edmonton. And this is not because of access to healthcare. this is not, in my view, something that is actually going to be solved by the healthcare system alone. It is something that is about changing opportunities, changing investments and changing priorities, looking at the different way the school system works and so on. It is a big and hard slog, but there are no structures within Alberta to deal with those sorts of issues. It is just an issue that is swept, in a sense, under the carpet, because we do, as someone said in a presentation I was at a couple of days ago, we are uncomfortable talking about some of these differences. So yes, I think we do need to invest in these things. The evidence, of course, for some of the primary healthcare investments are not strong, and so to some extent it may be a matter of faith and morals, but and values. But I think you're right that this is, if we are to improve life expectancy in this province, we have to address the tail end of the curve, if not more than trying to shift the mode.
Dr. Duckett, Lady Rose, I'm nursing faculty, long-time intensive care nurse. I'm curious, and I appreciate your comments on the determinants of health and primary care. However, so far this morning I've noticed that much everything has been hospital-based. We talk about our healthcare system and we equate it to the hospital. Is there anything that you can suggest to take our determinants of health and to remove those so that we are looking at a wellness model instead of an illness model of health?
A big question, and with no simple solution and no simple answer. These things are not shifted overnight. It's, as I said somewhere in one of the previous slides, they do not expect quick fixes on some of these issues. But I think, and I'm not a particular expert on this particular area, but when I was looking at my comparisons, for example, it was easy to get data on hospitals, almost impossible to get data on primary health care, almost impossible to get data on community services across the province in any consistent way. So in order to make some comparisons within the province, it was impossible, let alone between provinces in Canada. In terms of social determinants, as I said, the evidence, it is hugely complex to try and address that. But other countries have done much better than Canada, and other jurisdictions have done much better than Alberta. So some of the answer is that you've got to look at and acknowledge the issue and start to talk about it. But some of the issues are trying to actually make, trying to actually shape some of the behavioural issues. And one of the examples, a topical example, is sugar-sweetened drinks, for example. What are we doing about, I'm a supporter of increasing the tax on sugar-sweetened drinks to try and change the consumption patterns so we address some of the obesity issues in kids, rather than strategies which say that the answer is to blame people for eating. You know, that's just not sensible in my view. So we've got to look at some of the structural and system-wide changes that we need to actually make if we're going to try and change some of those things. But as I said, trying to move to a wellness agenda is actually quite hard. Partly because of, I had that slide about why it's so easy for people to think about hospitals, because we all conspire in that, including myself at this talk for them. I think I'm supposed to have a round. That's enough? Well, it's actually, I think we're doing a little round, well, not a round table, but a straight line here for one more then.
During your time as a CEO, is there, knowing what you know now, would there be any decisions that you would take back or do differently?
You reflect on this all the time. So I think with Alberta Hospital Edmonton, I think I tried to do too much too quickly with a lack of trust in the community. I think that's probably an important one. I think it's more not decisions I took, but decisions I didn't take, which I regret most. So I don't think I invested enough time and energy in skilling up the leadership of Alberta Health Services in actually managing a change agenda, in trying to actually do things differently, in trying to support them in dealing with issues like leaning out the system and so on. We were moving very, very quickly. So, for example, I discovered that I had to take $1.3 billion out of the system after I'd been appointed and before I actually arrived in Canada. And the longer we took to actually do that, the more the problem was going to emerge. It was going to get bigger because I had to pay the money back. So I focused too much on that rather than trying to build some of the capacity within the system. I might add, of course, that I'm actually quite proud of the fact that we actually did this without actually blowing up any hospitals, without actually reducing the number of beds in the province, and without actually reducing employment, in nursing, for example. So I think we did some things right, but obviously we could have done other things better.